Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Updates to Part 822 Outpatient Programs. And our presenters are Dr. Mark Manseau, New York State OASAS Medical Director, Pat Lincor, New York State OASAS Associate Commissioner, Tricia Shell-Guy, New York State OASAS Acting General Counsel, and Keith McCarthy, New York State OASAS Associate Commissioner. They will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation. Welcome to our presenters.
Hi, I'm Tricia Shell-Guy, and I am here with colleagues to provide folks some updates to the Part 822 outpatient programs based on regulatory amendments and guidance that will be issued. The intent for this presentation is for those who watch it to come away with a basic understanding of OASAS's intent in making changes to this outpatient regulation. We intend to convey a clinical vision that we have for certified outpatient programs, and that vision is to embrace addiction as a chronic disease and recognize that treatment planning is not a static exercise. It's not a few sheets of paper that you look at every 30, 45, or 90 days to refamiliarize the patient with their goals. Rather, it's an evolving document that may or may not change with each service as treatment continues, and these changes should be reflected in the plan and expanded upon in real time. We will also review the amendments to the Part 822, which operationalize this approach, and we will discuss future work to ensure we are reviewing compliance and providing sufficient guidance to enable providers to deliver this important work. So initially, I'll turn it over to Pat Lincor and Dr. Manseau to elaborate on the visioning behind the new regulation.
So thank you so much, Tricia. This is Mark Manseau. I just wanted to say a few words about the vision for this work and the purpose behind this work. So first of all, we really wanted treatment planning to be integrated clinically with the clinical treatment process. We don't want treatment planning to be an entirely separate document, an entirely separate process from the treatment that's being provided. We don't want it to be something that is simply an administrative task that you do every 30 days or 45 days or 60 days and don't think about it in between. And we wanted it to be truly integrated with the clinical treatment of the patient. So you think about when you go to the doctors, when you go to your primary care physician or a medical specialist, there is no separate treatment plan. The treatment plan is discussed with you at each and every visit, and any changes that are made to it consistent with your input and your goals, and then they are documented in the progress note by the clinician providing the care. We wanted the treatment planning and addiction treatment to be more similar to that, although there are, of course, some regulatory and clinical considerations that will make it still a little bit different, and we'll go into the details in a little bit. The second reason we did this is we really wanted to make treatment planning more integrated into the workflow of clinicians providing treatment, and we wanted to make that documentation less burdensome. We think that once everyone learns to document treatment planning in this new way, the burden on documentation on clinicians in addiction treatment programs will be much lower, which is a great thing. Pat, do you have anything to add to that?
So yeah, I think that's a great summary, Dr. Manseau. I would just add that this really is reflective of how counselors actually work with somebody. You will plan for goals and how people reach them, but it's very fluid, and those goals may change from time to time, and that's why the progress note we think is an excellent place to do that treatment planning in. And we'll talk a little bit more, and there will be some training that follows this about how to think about, including that plan within the progress notes. We don't want this to get too complex or to just recreate that very complex number of pages that usually a treatment plan is within the progress notes. We really want it to reflect the actual work that's happening with the person to set their goals and to document how they're working toward those goals.
I guess I'll just add that, one key piece of this is we really want this to foster collaboration and reflect, frankly, collaboration between the treatment team, including the medical provider and any counseling staff that are involved in the treatment, because we really we are worried that the way treatment planning had been done in the past really was just a document signing sort of administrative process that occurred separate from the treatment. And we really want the true team collaboration and work that happens in clinical treatment to be reflected in the clinical treatment planning process.
Translating that clinical vision into regulatory change, we're really trying to make the treatment planning process very flow, like we said in the previous slide, like the counselor working with the patient. And so facilitating the identification of goals, you would identify what they need and require to support those goals, and then seamlessly integrate that into the documentation of the treatment process. So really it's about following the natural progression of identifying within the assessment what the initial goals are. Generally, they are related to engagement and stabilization, may include some of the very initial goals that a person wants to accomplish. And you want to document that is being collaborated and talked with about with the patient in those progress notes to identify any changes in those goals or update with the progress that they're making in each visit. And so, one of the ways to do that is to make sure that every progress note talks about the goals that the person has. And it may not be every goal for every progress note. And it may not be that a person has more than one goal at any given time. It really is about matching what the actual goals are for that person to that individual patient. And making that progress note reflective of what's actually happening clinically. The signatures for acknowledging that the person has collaborated won't be required. So it's more important to make sure that within the progress note, you are identifying how that person is contributing to the development of the treatment plan and the goals that you are working on together. Mark, do you have additional things to add?
Yeah, I think you pretty much summed it up, but I guess I'll just come up with a brief example as to how this might look. I know there's going to be, as you mentioned, Pat, there are definitely going to be further trainings about exactly how to document this, but just as a way of a brief example to make it a little bit concrete for folks so they can envision it. So someone comes in and their initial goal is simply to prevent overdose. So they are receiving medication treatment, harm reduction services, and they agree to meet with a peer for further engagement. And so after the initial assessment, the initial treatment plan would be documented just like that. The person wants to prevent overdose, the person agrees to take medication, and the person agrees to meet with a peer for further engagement. But then after 1 month of treatment, the person decides that they actually want to really work on reducing or even eliminating their use of drugs. And so they agree to do group treatment to help identify the triggers for their drug use and reduce their cravings and develop skills to reduce drug use or eliminate drug use. And so you add that as a goal, and you add the additional group that they agreed to attend as an additional service in the progress note. You don't have to update the treatment plan. You don't have to save up that information until you get to the 30-day mark and include it then. You just add that to the treatment plan in the progress note.
So now we're going to go through a few slides that highlight some of the specific language in the regulation that changed, so folks can see how we turned this vision into actual rules. So before I get into the visioning language, we did take this opportunity to make some other changes to the regulation that were consistent with changes we are making more globally in our regulations. One of them was updating language to reflect our commitment to providing affirming LGBTQ services by using language that is gender neutral. We also eliminated some of the stigmatizing language by referencing substance use disorder instead of chemical dependence. And we were ensuring we were inclusive of problem gambling as an addiction by using addiction services throughout the regulation. We also used references to person-centered care. And finally, we went back to referencing opiate treatment programs instead of opiate full agonist treatment, given the numerous comments we had asking us why we needed to change it to something that seemed more complicated. Additionally, we made several edits to align this Part 822 regulation with our Part 830 regulation, which is the designation regulation that includes telepractice services, to accommodate all of the great things that have been happening in the outpatient system in the telepractice arena. So to do that, we took out references to face-to-face in the service categories, including peer services, recognizing that using face-to-face often leads to a debate over whether audiovisual telepractice services comply, and also importantly recognizing that telephonic services have been widely used, especially during this COVID pandemic, with great success. So this regulation was published on May 13th, 2020. The 60-day comment period ended in July, and we received a fair number of comments, many of which were very insightful and very helpful to us. Those comments have resulted in some additional substantive changes to the regulation, which I will go over later. And so consistent with the State Administrative Procedure Act, we will make some revisions to the regulation, repost the regulation for an additional 45-day comment period. We expect that posting to happen relatively soon, although I don't have a date at this point. Assuming this next 45-day period doesn't lead to additional further significant comments, we would anticipate the regulation will be adopted and effective in December of 2020 or early January of 2021. Okay, so what are some of the amendments we made to the regulation consistent with the vision for treatment planning, progress notes, and person-centered care? One of the things we did was make some changes in the standards that are applicable to all programs. And a couple of those notable changes included adding a requirement that policies must have, that programs must have a policy on toxicology. So the goal now being that toxicology should always be used as a clinical tool and not as a punitive measure, and that the frequency of toxicology should reflect that. We are developing guidance. HR and Dr. Manceau's office will be developing some guidance in that area. We also made some revisions to the section on problem gambling to reflect the requirements of Part 857, which is the section related to gambling regulation. We removed references to waivered populations and programs for gambling going forward, and now any programs that want to provide problem gambling will do so after they submit an application. They have the appropriate staffing, and once approved, that designation will be reflected on the operating certificate. Importantly also, we modified language about program hours by adding language asking programs to consider expanding hours and recommending evening and weekend hours to make it easier for patients to access the program. To foster the concept of treatment planning as an ongoing process, and as you heard Pat talk about, we made some significant changes with regards to the way treatment planning is done. we collapsed previous sections on admission, initial services, transfers, and readmissions, treatment and recovery planning, case records, and documentation. We consolidated all of this into a single section that we call patient records/treatment planning. We also utilized the term patient record instead of case record, and over time our other regulations will be updated to reflect the same language. We added a definition for progress notes and referenced their inclusion in the new treatment planning process. And, you know, many sections, many of the requirements under the sections that I spoke about above that had been collapsed, the admission, initial services, transferred, many of them remain the same, but there are some exceptions, some important exceptions. For example, there is no denying admission based on the use of substances, and there is specific reference that there cannot be a denial for a patient on benzodiazepines. We also added a section for screening for mental health conditions that includes suicide risk using an OASAS-approved tool. And I believe that HR and Dr. Manceau will be posting some guidance and a list of tools. Dr. Manceau, did you have anything to add on this?
Yes. In the past, we had simply said, you know, that the mini was approved in the CSSRS, but we have guidance now that we are working on that's pretty close to being finalized that really goes into exactly how mental health screening should be done and provides a more expansive list of tools that programs are able to use. So stay tuned for that.
So we made some changes to the language on the decision to admit, indicating that it needed to be approved by a licensed practitioner. We were intending to add a definition for a licensed practitioner that essentially mirrored what used to be in the reg, that being a physician, nurse practitioner, a physician's assistant, licensed psychologist, or licensed clinical social worker. However, we didn't add the definition, and then it seemed to cause some confusion. We did get a lot of questions and comments about that, and so after public comment, we're going to go back to the language that you see on the screen. We will change it back to reflect the actual list of practitioners that make that decision to admit. And so now I'm going to hand it back to Pat and Dr. Manceau to get into some details about, further details about our expectations for what the treatment planning process looks like.
As we discussed before, our intent is really to create a seamless, integrated treatment plan that's fully incorporated into the patient record and that evolves with the various progress notes that are used with each and every clinical interaction, so that it's naturally reflected in the treatment process. So you still do need a written treatment plan here, and it does still need to be developed by clinical staff. And you still need to work with the patient to develop it, and their goals and values must be incorporated into the treatment plan. And you still must identify the clinical services and supports that will support their recovery goals. It does not need to be signed by the patient anymore, although it does have to be developed in collaboration with the patient. And it begins really with the initial assessment, and then it's incorporated into the patient record and regularly updated with progress notes. There is no longer any requirement to have a certain, time frame for signatures every 30 days, every 40 days, every 60 days. Instead, the idea is it will just continue to evolve as the treatment progresses.
The treatment plan does have still criteria that are within the regulation, and it there does need to be an assessment that identifies a diagnosis that begins the plan. So the way we envision it is actually within the assessment, that there's a section that says initial plan, and there's a number of goals that are incorporated there. That it does have to be incorporated into the patient record. including some of those initial services that are offered prior to completing the initial assessment. So if you were doing pre-admission services or if a patient had goals that were developed even before the assessment was completed, that would be managed also in a progress note. So as you saw the person, and maybe the assessment is a part of the goal here, that would be just incorporated in a note. Then the date of the assessment happens. That's where you identify the diagnosis and that initial plan for services. You also want to address the patient goals, through that assessment process, and then regularly updated through those progress notes. So, really what the goal is here is to have it seamlessly documented throughout the other normal kinds of documentation that you have in the person's record. From, every visit or every interaction with the person should have a progress note. That should be happening in a clinic in all outpatient programs now. Then there's that assessment that documents, the assessment and that initial plan. And then from there on, the rest of the treatment planning happens through the progress notes. So there is a single member of the staff still who is responsible for managing that person's treatment overall. So while they may be involved with many members of the team, there's still an identified person who is the clinician who's responsible for managing that, the plan, and that's the person who would sign it. And that has to be signed by either a physical signature on paper or an electronic signature. That part hasn't changed. Also, there should be a note that that the information was reviewed with significant medical and psychiatric issues identified as part of the assessment process, and then the updated medications as issued by appropriate medical staff. This was one of the things that also there were comments. So because often medical and counseling notes are kind of separated in a EMR, people wondered, would the counselor need to be the one who identified the medications? And that really the medical staff should do that. And the medical staff, as Dr. Mansell was saying earlier, should be a part of creating the plan and documenting them in their own medical notes, so that the interaction of the entire clinical team is identified in the record, but through the individual notes. And then it needs to be reviewed and approved by the clinical staff person who did develop the plan, generally the person who's responsible for that person's overall treatment, the patient, and the clinical supervisor. So that is, the clinical supervisor would be somebody who would sign the assessment. For progress notes and for ongoing changes to the treatment plan, that also should be being discussed with the clinical supervisor. And we will talk more about guidance for how to document that.
Just briefly, so even though we got a lot of comments on this, as you mentioned, and they were really helpful comments. So we want to clarify that even though there will be a recognition that the medical providers are involved in the treatment plan, in the treatment planning process, and in the treatment, and that the medical issues and psychiatric issues and medications, have been identified and acknowledged, we will not be depending on non-medical staff to, review lists of medications or anything like that. There'll just be an acknowledgement in the progress note that that the medical providers are involved and that medical issues and psychiatric issues are being incorporated into the treatment plan.
So we define progress notes in the regulation consistent with the vision that we've been expressing. And I'm going to read you the definition because I do think it's important for folks to see how that definition has changed. Progress note is documentation of each service delivered and serves as the treatment recovery plan as it evolves to support person-centered goals and ongoing service and care planning. Progress notes identify patients' clinical status, types of service, and updates to goals, methods of treatment, and types of services provided, and include challenges and achievements identified. And so I think in that definition, you hear a lot of what Pat and Dr. Manceau have been saying in terms of expectations for how progress notes reflect ongoing treatment planning. For purposes of each service that providers deliver, we tie each service to specific documentation requirements in the progress note. So specifically, it needs to be signed by the person that's delivering the service. It needs to indicate the date of the service, and it needs to reference how this service relates to goals. And so you heard folks talk about, an update to goals to the extent that that service creates a new goal or changes to an existing goal. And so probably the most significant change from the previous regulation, if you were to just open up the regulation and start to read it, and from the way that programs operate, is the change to a treatment plan review. The idea that treatment plan reviews are ongoing and evolve through continuous progress notes. So from a regulation standpoint, how did we do it? It was actually pretty simple. We took out the former 90 and 180-day review time. We removed them out of the regulation and defined, as I explained to you before, progress notes and language that indicated how progress notes are updates. So as you've heard Dr. Manceau and Pat indicate, treatment plans are continually updated through progress notes. Now, before we did that, we did need to go look at some of our federal authorities, specifically our federal Medicaid authority, to look at what we had said in our state plan and other authorities with regards to how services exist, how they're delivered, and whether or not treatment plans had any specific timeframes. We were very pleased to note that we did not include specific timeframes in those authorities, so we did not have to do any updates or amendments. And so as has been said numerous times, progress notes should be addressing goals. This way, goals can be regularly updated, and the goals that are updated and reflected in these progress notes are reviewed during clinical supervision to ensure that they are consistent with the patient's needs. So we recognize this is a big shift, and as folks have said, we plan to issue guidance, assist folks with meeting these requirements, not only meeting these requirements, but delivering good clinical patient-centered care. Another big change to the regulations was that the previous regulation, and for a very long time, had a 30-day time frame for discharging patients that had no contact with a program. This has been revised now, and now there is an allowance for 60 days of no contact. So patients having no contact with the program for 60 days should be discharged unless there is a clinical reason for continuing treatment and that treatment is documented in the patient record. Some of the other significant changes made to the regulation concern opiate treatment programs. We specifically reference that take-home schedules must be consistent with federal criteria. If someone meets the criteria and there is justification for not allowing take-home, we expect that it would be documented in the record. The expectation is that take-home will be utilized with more regularity in the system, and in order to facilitate and accommodate that, we are seeking permanent federal approval to accommodate weekly Medicaid rates more consistent with the actual expenditures faced by programs that are doing more take-home. Take-home containers must be, you see it said child-proof. We fixed that. We edited that to tamper-proof, given some of the comments that came through. So from the public comment and consistent with federal guidance. So any take-home has to be in a tamper-proof container. And another thing that we reflected is opiate tapers. Opiate tapers are not the standard of care. While it may be appropriate in limited situations, that is by far to be the exception and not the rule. And where there is an opiate taper occurring, it should be documented in the record, and there should be an indication about the patient's request to participate in this taper. As I said earlier, we had a significant amount of comments that required substantial changes to the regulation, and so now the regulation will be out for another 45-day public comment. This slide is intended to highlight some of the areas where we received some significant comments and where we made most of the edits That would have been in the section on definitions and the opiate treatment sections. And so I just want to take a couple of minutes and go through some of these changes that were made as a result of the public comment. So one of the changes to the definition section included a reorganizing of that section. We alphabetized it, renumbered it, and then we made some clarifications. Some of the substantive changes to those definitions include the definition of complex care coordination. We removed the requirement for the service to be delivered within 5 days of another service, and you can look for additional guidance on that and refer to the guidance in the APG manual. Another change in the definitions is continuing care. We continued adjustments to this definition so that the field could understand the intent and purpose behind continuing care. We do have additional guidance on the website, but it's important to remember that the time period for discharge, as I said earlier, has changed and gone from 30 to 60 days unless there is another clinical justification noted in the patient record. However, there is that option to allow for the continuing care module for patients who need not necessarily be discharged completely, but would benefit from some ongoing continuing care. We also made some changes to the pre-admission services section. References in that section to specific services have now been removed from the definition, and pre-admission services, what are allowable as pre-admission services, will be identified in the APG manual and any additional guidance that we issue. In the opiate treatment program section, there were a couple of changes. Patients maintained on buprenorphine and significant others are excluded from certified capacity. The medical director must approve take-home medication. It can't be any physician that works in the program. It has to be the medical director. Physical requirements, while some level of medical assessment must be done in order to begin methadone and initiate methadone, a complete physical must be completed within 14 days. And split dosing. There'll be some additional guidance provided on split dosing. And that will include language that plasma levels are not required for pregnant women prior to split dosing, but programs will still continue to require OASAS approval prior to using split dosing. Some of the other changes not related just to documentation, or I'm sorry, not related to definitions and opiate treatment programs. Documentation of admission, it must include locator. We received that question numerous times, and so we actually put it in the regulation twice, just for clarity. It is important and it is required. Admission has to be approved by the dated signature, and that can be physical or electronic, as I said earlier, of a physician, physician's assistant, nurse practitioner, licensed psychologist, or licensed clinical social worker. So that was on one of the slides earlier. We put all of those individuals back into the slide specifically rather than leaving it open to a definition because it was causing some confusion. With regard to the language that we added about programs not being permitted to deny admissions based on the use of any substances, including benzodiazepine, we further added qualifying language based on comments we received that it be clear that this included substances that were either prescribed or illicit. So you couldn't deny for either prescribed or illicit substances. And the treatment plan, as Dr. Manso and Pat explained, we made some edits to include that the notes can indicate that a medical assessment and prescriptions were reviewed by the medical staff, not necessarily incorporated by clinical staff.
I think it's safe to say that the regulatory changes being effectuated by OASAS are intended to reflect as much a change in mindset for how our outpatient programs operate than a change in the actual service delivery model of the programs. Ideally, we believe these changes already reflect the core philosophies you all operate under in providing care and treatment to our population, working with the patient to facilitate identification of goals, needs, and supports, integration of those goals and needs into the treatment process, updating activities in the progress notes, et cetera. While trying to create a regulatory oversight structure that makes this work less of a bureaucratic exercise and reflective of more of an organic process. With that said, philosophical and mindset changes can oftentimes be the hardest ones to achieve, because it's not just about changing what you do, it's about changing how you view what you do. And when what you do is reflective of how you've operated over an extended period of time with long-standing practices, it can be even more difficult, maybe even intimidating, when you think about doing it differently. This is just as true for the regulatory oversight agency as it is for the regulated. That's why OASAS proposes being deliberate in the implementation of these regulatory changes. In addition to the training we're providing for the field, we're actively briefing vendors and our state agency partners. This extends to our own regional office staff, who of course are the ones who are charged with assuring compliance with OASAS's regulatory standards. In the shorter term, minimally, we will make revisions to the OASAS program review tool reflective of the regulatory amendments. We'll test this out, see how it works, identify any tweaks that may need to be made, and then incorporate into our existing processes. With the current pandemic, as I think you're all aware, we've recently begun institution of a new virtual site visit process, and we'll be learning from that as well. One could argue that all these experiences will give us great insight into how we can do things differently and more efficiently moving forward. As a result, longer term, in addition to looking to make the overall OASAS site visits more efficient and effective, we're looking to make the process less of a bureaucratic exercise, similar to what I touched on a moment ago. In particular, it's important to note that being in regulatory compliance doesn't always equate to quality care. Unfortunately, and this is true for almost all regulatory oversight agencies, the tools utilized often reflect more of a checklist of items, compliant versus non-compliant. Ultimately, where we're looking to go is an oversight process that seeks good care and practices versus regulatory compliance. Ideally, we want to judge our services more on outcomes versus compliance. We think that these regulatory changes can help us get to that end. It'll take time, yes, but that's our long-term goal.
I want to thank our presenters for today's program. I hope you all find them useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.